Hello, everybody, and thank you for the organizers to invite me to talk about celiac disease, which is no longer a rare gastrointestinal disorder of the childhood. My name is Sonja Bastian, and I'm a consultant for gluten-related disorders. I always start with this slide and this picture of the Stone Age man looking for food and preparing his food. We are still Stone Age people with our enzymes, our biochemistry, and our tissues and organs. But we do not live like Stone Age people. We eat fast food with ingredients which are not healthy for us. One of these ingredients is gluten, which is a center of my talk today. Gluten is the reason for celiac disease, and the awareness for this disease is very low. Although the prevalence for celiac disease is between 1.3 and 1.8% of the whole population of Earth. In comparison to a very well-known and very well-discussed disease, IBD, irritable bowel disease, it's much more higher than, for example, ulcerative colitis or the Crohn's disease. And this lack of awareness makes a delay in diagnosis for the patients. The delay of diagnosis is in between 10 or 13 years. And worse, the people suffering from celiac disease in between 4, 1 is still undiagnosed. Although we have constantly updated guidelines, and an availability of very good tests, and we all know the risk of complications of celiac disease, and that the quality of life is improved by the introduction of a gluten-free diet. Why does this discrepancy appear? Well, patients do not like to talk about their symptoms like diarrhea. There is in the healthcare providers a lack of clinical knowledge and an unfamiliarity with diagnostical methods you can offer in the lab. They often are unable to interpret the extraintestinal signs, and there is a medical inertia to the condition of gluten. During lifetime, you see different time courses for celiac disease. The classical form appears in early childhood and is present until the end. And there is an extraintestinal form which appears in childhood, disappears after puberty, and then reappears in adult. And the adult form, which is only present in adults. We have here a threshold, and there are some patients which do not cross this threshold, and they are the group of subclinical patients, which do not show any signs of celiac disease. You can see here the dotted line. That are time points where complications appear. Complications like cancer, osteoporosis, malabsorption, infertility, or neurological diseases. For the extraintestinal and the adult form, these time points are later. The classical CD I showed you in the previous slide, where symptoms like diarrhea, weight loss, and malabsorption only appears in 27% of all patients suffering from celiac disease. 21% do not show any symptom at all. And 52% do show symptoms like constipation, anemia, osteoporosis, hypertransaminasemia, neurological disorders, or dermatitis herpetiformis, skin disorder. Malabsorption is one very common symptom. If you compare the size of the surface of the gut from a healthy to a celiac disease patient, you see the difference. The gut of the normal patients has a size of nearly 600 square meters. In the case of an untreated celiac disease patient, it's only 1 square meter. So that is the reason for malabsorption. Here an example for a patient suffering from osteoporosis. A 34-year-old male patient was shown with a spontaneous fracture of the 10th dorsal vertebra. He was diagnosed for osteoporosis in young age, and other fractures obviously followed, like here in his hand. He was tested seronegative for celiac disease, so he was one of these subclinical forms. But he showed a villous atrophy in biopsy, and he was HLA-DQ positive. So here the diagnosis celiac disease was made. And he was so nice to provide a picture from early childhood. And here you can see that this boy suffered from celiac disease and malnutrition even in childhood. Another symptom are neurological manifestations. And in history, we found the first hint on this manifestation in 1908. And in 2013, more than 100 years later, we found the reason for that. That's the transglutaminase 6 autoantibodies, which are responsible for gluten ataxia. Anti-TG6 antibodies or anti-neuronal transglutaminase antibodies are present in some cases of adult celiac disease. Here we see a study of 100 patients newly diagnosed with celiac disease at a gastroenterology clinic. They showed neurological deficit and had 40% positivity for circulating antibodies against TG6. The result from the brain imaging showed that there was a reduction in brain regions in these patients, and that correlated to anti-TG6 autoantibodies, providing an evidence for a link between autoimmunity and the brain atrophy in these patients. Let's have a look at the patients in detail. The patient suffered from headaches, gait instability, sensory symptoms, and gait ataxia. They were tested at baseline and then at a 7 years later follow-up appointment. You can see here in the comparison of the two examinations that the headaches were improving, but we had an aggravation in gait instability, sensory symptoms, and in gait ataxia. And even worse, the sensory loss appeared first time in 13% at the follow-up appointment. They tested for the classical parameters in celiac disease, that is anti-TG2, IgA, and EMA, and anti-gliadin positivity. And you can see here at the first appointment, 100, or most of them, nearly 100% of the patients were positive. And they showed a massive improvement and a reduction of positivity after introduction of the gluten-free diet 7 years later. But how can you explain this aggravation in these other symptoms? So let's have a look at anti-TG6 antibody testing. And here you can see at the first appointment, we had 37% positivity and nearly no improvement after 7 years. If you make an overview over all serological testing, you see that here you had a 100% positivity in addition and only a 50% for the follow-up appointment, indicating that these people were not really fully adherent to their gluten-free diet. And the recommendation is that you should do a repeated testing, not just for EMA and TG2 antibodies, but also with AGA and especially TG6 to avoid neurological manifestations of celiac disease. This made it possible to create a guideline for celiac disease and other gluten-related disorders. And in paragraph 13, you can read, Gluten-induced neurological manifestations, including gluten ataxia, are seen in adult CD and occurs also in children. And that anti-TG6 has been found in up to 85% of the celiac patients with neurological involvement. And finally, new diagnostic tools are becoming available or are present with our test system to detect these patients with a so-called neuroceliac disease. The neurologists of London made another guideline on the diagnosis and management of progressive ataxias, because 20% of all patients with progressive ataxias show a gluten-related ataxia. And this form of ataxia is a treatable ataxia. So they recommend that all people with idiopathic cerebellar ataxia should be tested for gluten sensitivity, and that is a good practice point. And you should consider testing for antibodies against TG6 as the most sensitive test for gluten ataxia. You should recommend a good dietary advice and a strict adherence to the gluten-free diet, and this should be closely monitored with a 6-monthly testing to ensure the elimination of anti-gliadin antibodies and anti-human neuronal transglutaminase antibodies. And that is too possible with our test system. Why is this so important? We have here clinical courses of several ataxias, and we will focus on the gluten ataxia, which is marked here in bold. And here you see the most prominent clinical courses for gluten ataxia, that is partial recovery and stabilization. In the partial recovery, we have at first an aggravation of the disease, and after introduction of the gluten-free diet, you see an improvement and a stabilization. In the stabilization form, you have a worse aggravation of the disease, then the introduction of the gluten-free diet, and a stabilization. What does this mean? We have here the cerebellar reserve, the potential of the cerebellum to heal. And we have here the so-called restorable stage. If we start with a gluten-free diet somewhere in this restorable stage, we can improve the situation for the patient and reach a nearly normal stabilization phase. If we cross the border to the non-restorable stage, then the aggravation will go further and we can't improve, but we can stabilize the patient. That makes the wheelchair nearly impossible, but this here leads to a maybe self-defined way to live in a wheelchair. But there are other patients at risk for celiac disease you should keep in mind. There are people with skin diseases like psoriasis, urticaria, or rosacea, and malignancies. In the guideline, it's stated that these people should be tested for gluten sensitivity or celiac disease. And there are orodental signs like enamel defects, after stomatitis, or dry mouth. Especially if all these three come together, there is a high risk for celiac disease in the dentist's office. Another very important area are people with a present autoimmune disease like diabetes type 1 or Hashimoto's disease. Both have a 5 to 10-fold enhanced risk to develop celiac disease and should be tested annually. Additionally, people with reduced fertility, as men as well as women, should be tested for celiac disease. And people with chromosome anomalies like Turner syndrome or Down syndrome have an enhanced risk for celiac disease. And finally, some people with bleeding disorders have anti-factor 13 antibodies, and that is an autoimmune disease against coagulation transglutaminase, factor 13, And here we have the same situation like in autoimmune diseases. So consider testing in all these patients. We have a so-called IDK approach, which is patient-centered. We start with the signs, if you have gastrointestinal, dermatological, or neurological signs. Then you can test for the specific transglutaminase, which is significant for these symptoms. We have for the gastrointestinal disease the tissue transglutaminase, for the dermatologicals the epidermal transglutaminase, and for the neurological transglutaminase, all in the IgA class. Don't forget to test for total IgA, because if there is an IgA deficiency, you have to skip to IgG testing. Then you can use the anti-TTG IgGs in serum or the anti-HNTG IgG in serum too. In some cases, for example, in the early development of celiac disease or during the diet monitoring, you can use TTG testing in stool. There are very small amounts visible if there is, for example, a dietary error. Don't forget that there might be cross-reactivity. That means you start with anti-TTG testing, and later on he will have neurological symptoms, and then you have to test latest for NTG too. So there are a lot of information on different testing. How do you interpret these results? We have here the celiac disease with 5 different forms: the symptomatic, subclinical, refractory, potent, and seronegative. The first 4 are normally positive for anti-TTG. Seronegative forms, like the patient with osteoporosis, may have a negative result in the antibodies. All of the 3 and the one with seronegative result are positive in the biopsy for MARCH2. Only the potent latent, which is positive for the antibody, may show a negative result in the biopsy. For the neuroceliac disease, you have a positive for NTG, and for dermatitis hyperdiformis, you have the positive for ETG and sometimes for TTG too. Sorry. All of them are positive for HLA-DQ2 or 8. But you can't consider that everybody who is positive for HLA-DQ2 and 8 will be positive for celiac disease and will suffer from this disease. So this is only a confirmatory test to say that these patients you tested positive for any of these antibodies will suffer from celiac disease. We have to discriminate to wheat allergy and NCGS, the non-celiac gluten sensitivity. These forms are negative for all antibodies and for MARCH. They might be positive for HLA-DQ2 and 8, and they might be positive for several other antibodies. Intestinal fatty acid binding protein is positive, especially in the refractory celiac disease, which is a disease which do not react on gluten-free diet. So I told you it's very important to monitor the gluten-free diet to avoid complications. You have different tools in your toolbox. For example, the questionnaire, which is very time-consuming. It lasts for 90 minutes, and it may escape reality because your patient doesn't tell you everything, and it's not objective. You interpret the answers he gives to you. Then you have the symptoms. They are quick in onset, but they are very variable, and not all patients show symptoms. And you have the anti-TG2 serology, which is widely used, but reacts very slow. For example, it gives a positive result 14 days after a gluten challenge. But it is very useful as a biomarker at 3, 6, and 12-month follow-up appointments after the gluten-free diet introduction. So it's a long-term adherence biomarker. comparable to the HB1AC used in diabetes monitoring. It is therefore useful to differentiate between complete, partial, or non-adherence. The fourth tool you have is the detection of glute-immunogenic peptides in feces or urine. You can detect this in feces 2 or 7 days after a gluten challenge, or in urine only in hours after gluten challenge. So that is a non-invasive and easy-to-use, highly sensitive test to detect traces of directly ingested gluten. So you can detect a dietary error, for example, if a patient appears with symptoms. The biopsy is the last tool. It's an invasive and too, like the antibodies, a very slow method. And you should reserve that because of the invasiveness to cases with no clinical improvement or no decrease in the serological titers. That is the detection of the so-called refractory celiac disease. So if you do that, when should you do that? And what should you do at the different appointment? You have here different examination methods and parameters. And you see here the different dates you should plan for follow-ups. You have the 3-month and 6-month follow-up, which is directly after the initial diagnosis, and then an annual follow-up, which should be a routine testing. And you can see here in gray the routine parameters. That is the questionnaire, that is anti-TTG testing, and that is EMA testing. That should be done at every of these appointments. If there is an acute onset of symptoms, you should do the urinary GIP testing to see whether there was an actual dietary error. Best practice is to avoid complications, to test neurological transglutaminase at every appointment, especially at the annual reappearance of the patients. And the gold standard for monitoring of the gluten-free diet is the fecal GIP testing at every appointment. What can you say if you have some pathological findings? You have the general poor adherence to gluten-free diet if the antibodies stay high. If it is high more than 2 years after introduction of the gluten-free diet, you should consider a non-responsiveness and refractory celiac disease and perform a biopsy. If you have positive results in the GIPs, then there is a dietetic error and you should give the patient dietary advice. So now I'm at the end of my presentation, and I thank you for your attention, and I hope I gave you an idea to make patient-centered diagnostic and monitoring in gluten-free diet and in celiac disease. Thank you very much.